Here, let me put it there too.
Absolutely, yes. First of all, I thank you for inviting me to this show. As you mentioned earlier, it's unusual to see an engineer on a medical television program. Engineering and cybernetics, in general, are opening up great prospects for medicine. So let's talk about the possibility for a doctor to access actionable scientific knowledge, the practical, operational kind, which allows them to make decisions in the field and prescribe therapies with just a click digitally. I'm referring to what Professor Lignari said earlier, that every 10 years, medical scientific knowledge is regenerated. You should know that every year. About 1 million studies are produced in the world of scientific research, and they are added to the largest medical database we know, which is Medline, also known as PubMed. Now, the goal we set ourselves is this: to give all Italian doctors, in this case, from the province of Catania, the opportunity to access the studies, to the work that comes from the world of research. We have provided the order with a system for accessing literature and helping doctors extract clinically relevant results that impact diagnosis or therapy. So basically, we have provided the order with a holistic system that starts from access to primary literature and then systems that help the doctor digest this literature, extracting the results that are clinically relevant, those results that somehow change the doctor's life, whether in diagnosis or therapy. Let's take a concrete example. Let's say we want to address the issue of flu vaccinations. Thank you. As you can see from the screen, this is Dynamed, the evidence-based support system. The doctor can simply enter a search query. They can formulate a clinical question, in this case, flu vaccination. You can immediately see that, the system offers you two options, adults or children. So if the doctor, feel free to move to the next slide, quickly identifies the clinical topic of interest, you see influenza vaccines in children, they click on the topic and basically view a summary of all the actionable scientific technical knowledge. Please go ahead to the next slide. That helps the clinician perform all the activities and make the decisions that need to be taken in the clinical setting. You can immediately see the date of the last update. Here, the doctor can understand what the latest work or study was that had clinical relevance and came from one of those 5,000 journals on PubMed that we mentioned earlier. Do you see on the left, the doctor has the ability to navigate through actionable scientific technical knowledge using taxonomies. For example, they can identify the latest updated guidelines, or they can find all the reports from the Centers for Disease Control and assess the risks that may be present. Let's move on to the next slide. Or, for example, to see what the latest works are, along with their levels of scientific evidence, and also to activate, meaning to open, the full text through the link. You see the link to the full text and the original source. This article, this study comes from the New England Journal of Medicine. So the doctor can access the works with a summary of the results that they can put into practice. And if they decide to delve deeper, they can still access the full text made available through our Medline Complete database. Now, this is another example of a clinical topic, Crohn's disease. The idea here is to provide the doctor with a sort of super updated quick reference guide in real time, where they can find the answer to any clinical question regarding Crohn's disease in just a few seconds. And not only the answer, but also all the evidence, the works, the studies that produce the answer along with their respective levels of reliability. The professor mentioned the conflict of interest earlier. One of the huge tasks we undertake is examining how studies are produced. So, a so-called critical appraisal is done, the critical evaluation. This is to provide the doctor not only with the final results of the study, but also to give an indication of how reliable these results are. Why? Because the doctor makes decisions based on the summary, on the conclusions that come from this evidence. Let's take another example. Dr. Soteria was talking about diagnosis. Another system we have made available in the order is the Isabel Healthcare module, which is an automatic diagnostic hypothesis generation system based on a clinical picture. Here on the screen, we have software that allows a doctor, whether it's a general practitioner, an emergency room doctor, or a specialist, to enter data related to a patient's clinical picture. You see a screen. Now I don't know if the users at home will be able to see it clearly, where it's possible to enter the patient's data, age, sex, and the signs and symptoms. In this case, for example, you see fever, and the system automatically generates all the possible causes of fever, while in action, even directly, on the portal, even on the smartphone, because there is an app available for smartphones. So you can enter the data related to the patient. Let's move on to the next slide. This includes not only symptoms and signs, but also, for example, results from blood, tests, and laboratory exams, and get help from the system to generate a list of diagnostic hypotheses. Let's move on to the next slide. You see that we filled in fever, erythema, and itching. Let's move on to the next slide. You see that the system automatically generates a list of diseases that may be compatible with this clinical picture. You see, just like before, I can't even read it now because, for example, Lyme disease might be a rare illness, but the function of this software is to help the doctor consider all the possible diseases that could be responsible for a clinical picture, even going beyond the personal biases that each doctor has, thus helping them correctly define the differential diagnosis. What you can also do is, once the list of possible diseases is determined, go deeper into each disease to check what the appropriate diagnostic tests are to perform. So, for example, if we go back to the previous screen, you can see that the doctor can. Let's move on to the next slide, delve deeper, and let's go to the next slide, ask about Lyme disease, for instance, because it came up. What does Lyme disease have to do with a 40-year-old male patient living in Italy who has these symptoms? So the system explains to you why this disease was brought up and also tells you the degree of correspondence with the clinical picture you entered. If we move on to the next slide, you can see that the system explains in detail what the common elements are. This helps the doctor to reason, to find logical connections between concepts in a vast sea of scientific knowledge that is medicine, which is enormous, complex, and always evolving. The ultimate goal is to enable the doctor to be quicker in making the reasoning that leads to diagnoses and prescriptions. Here, for example, you can also see the option to filter for so-called don't miss diagnoses. There's a lot of talk about medical errors, clinical mistakes, defensive medicine, and what we call poor healthcare. This software allows the doctor to quickly say, be careful, given this clinical picture. Make sure right away that these are not the diseases responsible. Why? Because if these diseases are in question, the patient risks their life or faces serious consequences. Let's move on to the next slide. You can also see how, from Lyme disease, for example, you can instantly access the entire section on the diagnosis for Lyme disease, and not just that, as you can see in the circle on the right, but you can also see that the system has generated an automatic query of all the relevant knowledge sources that doctors need. So, for example, it has queried all the results from Medline Complete, all the images, PalMed, the Center for Disease Control, and the WHO, which are the repositories of the World Health Organization. So you see how, in just a few seconds, the doctor can define a list of possible diagnoses based on a clinical picture and explore all the relevant aspects within each diagnosis, each disease.
Professor Basile, we thought that this type of activity was the exclusive domain of researchers, but we've seen that it can actually be a great working tool for doctors who don't do research but engage in daily clinical activities.
Let's also think about those who do research. This is a system that allows you to have complete scientific knowledge on a topic in a very short time. I was thinking, while the engineer was speaking, about the beginning of my career when, for scientific research, you had to spend days and days in the library searching through volumes. Now everything is different, and it's crucial that this system is available to all doctors, especially those who do research, because research has accelerated significantly. This system allows us to quickly acquire scientific knowledge and also to select relevant information. Moreover, it gives all doctors the opportunity to educate themselves on specific topics and, as we've seen, to make diagnoses rapidly. Of course, we need to know how to use it, because another thing I was thinking about while listening to the engineer is that we must always look at the patient, examine the patient, take care of the clinical aspect, talk to them, not just type in the symptoms, because otherwise we would fall into another mistake. So the exact mix of both things, clinical aspects and online research, starting from the symptoms of the type of disease we are facing, will definitely lead to a quicker diagnosis and also to healthcare savings, because obviously only targeted investigations that are absolutely necessary will be prescribed.
Professor Buscema, I was just thinking a moment ago while the engineer was explaining these steps that it might seem at first glance like there's only space in this transmission for industry insiders. However, I'm convinced of the opposite, that the user, the citizen, the patient, whatever we want to call them, is perhaps the main recipient of all this, because you have organized everything to improve care.
Exactly, Dr. Siaka. Just a small introduction. We are facing a system with impressive potential that provides significant support for clinical reasoning and the cultural growth of the colleague, the doctor. So huge potential in this and for this. I asked Engineer Di Bello that it's not enough just to have acquired this system. He will come to Catania to organize 10 courses, each lasting 1 to 1.5 hours, aimed at doctors. So, as Professor Basile said, we need to be careful. The system is there. It has great potential, but it must be easily accessible and usable by our colleagues. So, in the coming months, the effort we will make as an organization is to organize 10 events where 200, 300, or 400 colleagues will participate. They will be explained step by step how to make a proper synthesis between the reasoning we've done so far, talking to the patient, immersing ourselves in the patient's reality, and the support that science provides us today, which can help in this knowledge process. And then we'll open another discussion about how important this knowledge process is. Of course, all these efforts are not ends in themselves. The ultimate beneficiary can only be the patient. So this huge amount of work is done solely and exclusively for the patient. So the effort of doctors today, there's so much talk about medical malpractice, so much talk about doctors' disinterest in their patients, but all this effort behind the scenes, which the patient may not realize, is the significant work that doctors do day after day, ultimately benefiting the patient and the patient's health. Another point was briefly mentioned. Today, in the Italian system, the costs of defensive medicine are no longer sustainable. Today, we're talking about 13 billion euros a year that are consciously and unconsciously wasted in clinical procedures due to what's known as defensive medicine. Of course, the proper use of this system could significantly reduce these costs, which could then create more room. Professor Basile was just mentioning that we are in a period of spending review, and the number of spots for access to specialization will be cut from 4,500 to 1,800. So if we can see where we can cut back, where we can save on those unnecessary expenses, maybe we could dedicate more spaces and more funds to training, even through specialization positions. So this whole process needs to be directed, it needs to be well guided, and in this, engineer Di Bello will be put to the test by us and will often be present in Catania.
All right, let's wrap up this extensive segment that Prima Linea Salute has dedicated to training with one last question. Professor Vigneri, we started by talking about a balance. We said that you were among those who firmly believed in and contributed to creating this ECM system in our country. So how do you see it now? In the future, what aspects of this system should be strengthened or improved?
So, I would like to start with a very brief introduction about this tool that has been made available to the Medical Association of Catania. Of course, as Professor Basile said, this doesn't take away from the history we need to gather from the patient and the clinical examination to find the signs and symptoms that we then need to input into the system. This is an important aid to clinical reasoning. As Professor Buscema said, a support for clinical reasoning. What does clinical reasoning actually mean? It means that we take some observations, some things we see in the patient based on our experience, based on our history, what we've seen and what we haven't seen, what we've studied and what we've studied a bit less. We then create a sort of summary in our minds, and using what's called inductive reasoning, we say the most likely thing is this, the second most likely is that, and then we confirm it with other analyses. What does this system provide us? By inputting, as if it were our brain, the various signs and symptoms we have next to us, but on our phone or tablet, not necessarily inside the office, a list of possible diagnoses available. There are the top 10 at first, and then you can look at the others. Now I ask, for patients who have fever, rash, and itching, adult males, how many of us would have thought about the possibility of Lyme disease? It's a rare syndrome. In Italy, there will be 100, 200 cases a year. Very few, almost no one has ever seen it. Here, a light bulb goes off that says, pay attention among many possibilities. There's also this one, think about it. If you have any doubts, these are, I remind you now, the main crises. If you have any doubts, do these tests. So it provides significant support for clinical reasoning. This system in CME offers an advantage. Clicking allows professionals to update themselves and stay informed about patients. It provides questions to evaluate learning after patient review. If someone clicks at a certain level and says, I want to use this moment where I am actually updating myself, I'm learning in the context of my profession, in relation to my patients, I'm keeping myself informed. If I click at a certain point in the system, provides me with a series of questions to assess whether, having read, looked at, and compared with the patient, I have learned And so with this method, can earn CME credits. Look, this is of great interest because while so far we have the ECM system, continuing medical education, which is quite rigid and structured, what we are moving towards is called CPD, continuous professional development, continuous development of our profession, which is obviously individualized. So mine and yours, since we see different patients, even though we are specialists in the same field, I see more childhood diabetes and you see more adult diabetes, but each of us has a profession, a specificity that can be addressed with this continuous professional development. It's not easy to do, but this model is the first system that tailors training to the individual needs of the doctor at that moment with those patients during their practice. So there's a significant advancement on a path that we will take because we will complete the CME system with incentives, penalties, and general dissemination, but then we will need to individualize it, paying attention to individual quality, and this system helps us with that.
Thank you, Professor Vigneri, and thanks also to Professor Basile, Professor Buscema, Engineer Di Bello, and Dr. Sotera. We'll be back in just a moment to talk about women-friendly hospitals, which have received recognition even in Sicily with the so-called pink sticker, and about medically assisted procreation,